Good afternoon, everyone, and welcome to today's webinar, Is There a Cure for Employee Surprise Medical Billing? Presented by the Validation Institute and also our friends over at Health Rosetta. We've had an amazing turnout for today's webinar. There's something like 1,300 plus people that have registered for this event. Many are listening live now, and many will also be listening after, because you will automatically receive a recording of the event. So we're going to go ahead and get started. Next slide. Great. As we move into the webinar here, I just want to give a little bit of background on the Validation Institute. We do three things. We validate, educate, and connect. You may have heard of the Validation Institute and the service that we provide to help validate the marketing claims that solution providers are making. We get in there and work with the vendors and validate the marketing claims, which is very helpful to the employers and buyers of healthcare. The thing we're most excited about, we just want to make sure everybody's aware of, is the launch of the Certified Health Value Professional Program for employers, which now is recognized and counts towards SHRM recertification credit. So for all the employers that are on the call today, and there's many of them, please make note of this. This Certified Health Value Professional Program is now really spreading quickly across the country and has 14 modules of an amazing online learning for many of the things you're probably dealing with right now as you're going through the cycle for buying healthcare benefits. This will help you identify top providers, help you understand the best benefits to bring into your company, and dramatically lower costs. So the Certified Health Value Program, we will follow up with everyone with a message on that, but we want to make sure you're aware of that. Next slide, please. And we also want to make sure that you're aware, another thing we do is we're in our third year of the Health Value Award Program. And the whole point here, again, as a benefit to employers and no cost to employers at all, we scour the universe for the best-in-class solution providers, bringing quality services and lowering costs for employers. And we highlight those at the Health Value Awards, which will happen at the World Healthcare Congress in March of this year. So watch for that as well, and we'll send you a follow-up. And if there's a quality solution provider that you work with and love, please nominate them, and we will give you information in a follow-up email on how to do that. There's no cost to you at all. We're just really trying to recognize quality. Next slide, please. So we have just a phenomenal lineup of speakers here today. And they're all going to get a chance to present on this very, very hot topic. So you see here on your slide our speakers for today, and we're going to get right to it. Next slide, please. And I'm going to hand the mic over to Al Lewis, who is going to take us through this amazing lineup of speakers on this hot topic. Al.
Okay, thank you very much, RD. You can see that the agenda is in the form of a diamond. It's because we're going to put some things, we're going to show you a little bit of background. Brian's going to show you an actual surprise bill. And then we're going to talk about the two components of how you are going to be able to solve the problem of surprise billing for emergencies by first having Marty Makary, Dr. Marty Makary, present on battlefield consents, and then talk about benchmark pricing, and then we're going to put it all together. So with that, I will turn it over to Brian Klepper.
Good morning, everyone, or good afternoon. Thanks, Al. This claim that you're looking at is just a tidbit of a 5-page claim that arrived to a hairdresser in Oriental, North Carolina, who had pains, went into the emergency department, was given an emergency appendectomy, and received a bill for $39,000. The next slide, please. The patient was told that bill reflected a 40% discount off of charges. It's undergoing professional review now, and we're probably going to send it to the state for an audit. This is from East Carolina Medical Center in New Bern, North Carolina. The claim is incomplete. It has missing codes. It doesn't specify the formal procedure that the patient received. Many items are missing CPT or HCPCS codes. Professional reviewers suspect that many services were unnecessary and the patient was charged for products and services that didn't happen. And our understanding is that the patient has now received a more complete bill as well as her patient record, but she's had to beg and plead and wrangle to get hold of both the complete billing information and her patient record. Next one, please. There are more than, there are tens of thousands of these cases a day, particularly with low income and uninsured patients who are pretty defenseless. As Marty has pointed out, this kind of behavior is an abuse of many hospitals' mission and their not-for-profit status. And also, in the state of North Carolina, where this case happened, the hospitals often receive additional funding, disproportionate share funding for taking care of these patients, so they're double dipping. It amounts to a shakedown of the patients as well as the taxpayers. So with that as sort of as we've got a live case going. With that, let me turn it over to Marty.
Marty?
Thanks so much, and it's a real honor here to be on this call with so many experts. So I'm looking forward to hearing what the others have to say. You know, as I've gone around the country defending patients, both to hospitals and in court, among the patients that are sued to have their wages garnished because of not paying for an inflated medical bill or surprise bill, I've heard a couple themes come up. And what I love about the work of so many of those on this webinar is that they are trying to empower patients with good information so we can address this issue up front. I've also been reminded how most Americans don't live like me. God's been good to me. I'm a surgeon. I've never really struggled financially in my career. Most of America has less than $400 of cash in their savings account. And I think we in healthcare, the medical establishment, and those on the end of the administration sending out these bills sometimes forget what it's like to struggle. People are living paycheck to paycheck all around us. And we doctors deserve to be paid for our work. Hospitals need to be paid for their work. But it's these egregious money games of price gouging and predatory billing practices that are not only costly and exhausting, they're now threatening the great public trust in the medical profession. 64% of Americans now avoid or delay medical care for fear of the medical bills. So there's some important things that I think we can empower patients with. First of all, I tell patients, when you come in with an urgent or emergent condition to the hospital, you don't have to sign your financial life away in perpetuity worldwide. You don't have to sign a document saying that you agree to pay whatever prices are produced without being able to see those prices and are willing under penalty of law to agree to those prices. Hospitals are required by the EMTALA law to take care of anybody that comes in with an urgent or emergent condition, regardless of one's ability to pay. That's the law. And by the way, it's also the great heritage of the medical profession. The mission statement of many hospitals when they were founded and their charter statements say that they will care for those in the community regardless of one's race, creed, or ability to pay. You don't have to sign these forms that sign your financial life away. I tell folks if they don't feel comfortable, if there's no prices offered, if it's an urgent or emergent condition, cross out those lines on any paper consent. If it's a consent on an iPad and it's electronic, you can simply sign "did not read" under the signature line. And it makes it clear that you're not agreeing to sign your financial life away. At the same time, you can consent to treatment. That is a different social contract. Agreeing to let us surgeons or doctors take care of you is a separate agreement. And that agreement is civil, is between a doctor and a patient, and it does not require that you financially sign your life away. I think it's important for folks to know that. There are also things that hospitals can do about surprise billing. If patients can do a lot by being educated, hospitals can also do a lot. Hospitals like my hospital has a closed staff model where all bills are in the master bill. Those master bills are all inclusive, and so it reduces surprise billing. At hospitals with an open staff model, that is, they hire physician groups to provide different services within the hospital. Some CEOs in the United States principle that they don't want their patients gouged with surprise bills from practice groups, have required in those contracts with the physician practice groups to have in it that they will accept patients where the hospital is in the network and that they will not charge more than the in-network fee for those patients. They've made that a condition of their contracting with the hospital. That's impressive. When a hospital does not have to put language in the contract with their private doctors that they contract with, requiring them to behave on surprise bills, but insists on doing it because it's the right thing to do, that's a model for the rest of the country. Payers can do something too. You know, simply giving away free money for certain bad behaviors promotes those bad behaviors. And every now and then, practices will put out, hospitals may put out massively egregious inflated bills with hopes that some insurance company or payer, maybe it's an employer, will simply pay out-of-network bills at 100% of whatever's billed. That feeds the bad behavior. Finally, the media and citizens have a role in creating public accountability around medical billing practices. I've outlined on the restoringmedicine.org website with my team 20 things somebody can do if they get an unfair medical bill. One of the little secrets in the industry is that many bills are negotiable before, during, and after care. So people should know that you can start with a civil conversation, but feel free to create public accountability by going to the doctor. Many people are afraid of bothering their doctor with an inflated bill. We found that when we go directly to doctors and say, hey, look, the patient you cared for got this egregious bill, the doctor is outraged and they want to fight on behalf of the patient. There are many things people can do beyond the doctor. Talk to a hospital executive, even board members. I'm proud to be on a hospital board myself, and I can tell you the job of a board member at a hospital is not simply to go there and just agree with everything. It's to create public accountability on a local level for that hospital. And billing quality is medical quality. We'll be releasing soon metrics of billing quality, arguing that financial toxicity is a medical complication. And taking care of a patient is taking care of the whole person. It doesn't make sense to take care of somebody when they come to us at a time when they're vulnerable, cure their disease, and ruin their life financially. So billing quality is medical quality, and we will have basic metrics of billing quality that will be released very soon that will be used for different hospital rankings and ideally for how we view the quality of an institution. So thanks for having me on.
Actually, Marty, you're ahead of schedule. Do you want to tell the story about the woman with the ER bill who came to you and kind of bring what you just said to life? Or if you like, we can use the extra time for your being ahead of schedule for me to tell everybody what a great book you wrote.
Maybe we can do both. So my friend went to the emergency room. I went with her and basically said, look, she needs care. This is an emergency condition. She's not going to sign this consent that has built into it that she'll sign her financial life away in perpetuity under penalty of law. That violates the public trust in the medical profession. And by the way, it's against the law. EMTALA law requires hospitals to take care of patients. If you're not going to take care of her right now, please let me know that you're violating the law. Well, of course, the person I was talking to does not know the EMTALA law, does not know policy, and was simply given this form to pass on to my friend to sign in the emergency room. Well, we were not able to cross out the financial, signing her life away. So since it was on an iPad and the signature line she'd signed did not read. And if that bill were to ever go to collections or to court, you better believe I would argue on her behalf that she never entered a social contract. That hospital then chased her down for bills. I made a reasonable offer on her behalf for her to pay the reference-based price, the sort of going market price, and the hospital would simply not budge beyond what they described as, a generous discount off a very inflated number. Well, I basically said, we're not budging. We're going to do this in principle. You can either accept the offer was the Medicare allowable amount, or you can take nothing because she's not going to pay anything. And they decided not to budge. They got paid nothing. So instead, because she wanted to contribute for her services, she donated money to the hospital and got her name on a nice plaque in the hospital wall.
So that's a great story, and I think there are many like that don't always end so happily. In Marty's blockbuster expose that I got to tell you, I read it the day it came out. The price we pay, and you'll get the opportunity to download it. I'm sorry, to click on the links and the Amazon that will come with this presentation, and I recommend that everybody buy it. And with that, we will go to the next set of presenters. So you heard about battlefield consent. You heard about the fact that you don't have to sign what they put in front of you. You heard about the EMTALA law, which is the Emergency Medical Treatment and Active Labor Act of 1986. And we're going to come back to that. But that's the law that basically says if you walk in the door with an emergency, you can't be turned away if you consent. So with that, I'm going to turn it over first to Marilyn Bartlett, who's done an amazing job for the state of Montana on benchmark pricing. And then David Contorno is going to talk about the same and what he's done for his clients on benchmark pricing. And then we will put it all together. So with that, Marilyn, I will turn it over to you.
Thank you, Al. Thank you, Dr. Makary, too. Your book is incredible. I have to tell you, I'm reading it a second time as I've underlined so much and tagged so many pages. It's excellent. It's an excellent resource. And I really applaud your next step to go to metrics of billing quality. As I speak about what we did in Montana, I have a lot of negative comments come to me from insurance carriers who claim I never looked at quality and I never looked at value. And I've always argued that value is a combination of price and quality. So I'm anxious to see you roll out this next phase. But what we did in Montana, I came to the state health plan in late 2014, and this chart, the red line, shows you the actuarial projection of reserves. Reserves were projected to be at minus $9 million by December 2017, unless we did some drastic things to turn the plan around. And the blue line shows you exactly where we ended up. Instead of minus $9 million, we ended up at $112 million. And the biggest part of that story has to do with reference-based pricing, and mainly for the hospitals. So what we started looking at is that 43% of our total spend were just the Montana hospitals. And the biggest chunk, 87% of that 43, pertained to the 11 large hospitals in Montana. So we knew that we had to deal with that. So we started studying the discount off of billed charge, a charge amount that you can never see, and we started seeing the flaws in that. And we used this chart quite a bit, which is put out by the Healthcare Cost Institute, and they do this annually. It's on employer plans. And the orange line shows you utilization. Now, utilization for inpatient was showing a slight decline. Outpatient was stable, and I'm certainly not saying those are good numbers, as there is waste and overutilization in those numbers. But they were showing fairly steady at a very high amount. But look at that blue line. That's what price was doing. Price was going right on up. And I claim it was because of the billing methodology, the discount game that's been perpetuated by carriers and brokers, so forth. Next slide. So then we also use this that I really found intriguing. This is inflation-adjusted price per inpatient stay. And the dashed blue line shows you what Medicare reimbursement is, and the red is what private payers pay. And this to me told the story. And I also did just a simple Excel graph showing what our plan paid, but it was just for semi-private room, and could show that line going up, billed amount, charge amount, and the allowed amount just going sky high while the Medicare amount was staying fairly flat. I then studied the methodology that MedPAC uses, the cost reports that come in, how they analyze, and their goal is to reimburse variable cost plus 8%. So I came to think that this would be a good benchmark. Next slide. So what we did in Montana, we said, okay, we will reimburse outpatient, inpatient, and providers as a multiple of Medicare. And why we selected Medicare as the reference point is that it's a common reference. The methodology overcomes variation in the charge masters. They're the largest healthcare payer in the world. The prices and methods are empirically based. The prices are intended to be fair, and they actually use quality measures in their value-based payments. They now have their hospital value-based payment system in, and they vary it for geography. So we thought it was the very best measure. Now, within the state of Montana, our goal from the legislature and the governor's office was to have no balance billing. So this meant I had to do contracting. Yet, if a facility would not contract, we did implement a travel benefit. But the nicest thing about this is I knew I would have some control over future reimbursement increases. They would go up as much as Medicare did, but would not go up by an arbitrary change to a charge master. So this became our strategy. This is the blended inpatient and outpatient costs to the plan within Montana. And our strategy there was 271 points spread difference. So our strategy became, over a 2.5-year period time, is to reduce that spread. And we did negotiate with the hospitals. In the end, we were able to get contracts with every hospital, not right away, but we were able to get the contracts to achieve that. And there were other side benefits. We moved, of course, to DRG, and that alone had a lot of savings in it. Now, the provider rates, in most cases, there was a slight increase, except in the facility-owned doctors. Critical access hospitals were pretty much untouched. A couple had rate increases. There were 3 that we did negotiate down, and those 3 are owned by larger facilities. So in the end, we were able to get contracts, but we did have a period of time with the travel benefit. Now, this is just within Montana. Next slide. What we chose to do was to not have a network. So we do not have a network, but our summary plan document spells out what a procedure-based maximum expense is, a PBME, and this is what we will pay. And what we pay will be determined by the geographical location and other considerations of that particular service and facility. It applies whether the provider has agreed to accept it as full or not. For those that are not participating, they are reimbursed at the lowest PBME established by the plan. Emergency services applies only during the time the medical emergency exists, and will cease when the patient is stable or no longer emergent. Then what we defined it in the plan, it applies to all provider reimbursements, and balance billing may occur for a non-contracted provider. And then we're going to hear a little bit more about the forthcoming battlefield consent that will apply for emergency care at hospital-owned venues. So that's what we did in Montana.
Okay, Dave, do you want to, David, I'll hand you the talking stick here. David, we can't hear you. While
Sorry,
oh,
my
there
fault.
you go. Okay.
Should be fixed.
Okay.
Sorry, had to hit that unmute button. I apologize, guys. I'm getting over a little bit of a stomach bug of some sort, so I'm not 100% myself, and I'm working from the house today. But I am here and grateful to be here, especially with everyone else that's on the panel. I think a lot of people said a lot of good things. Obviously, Marty's book really helps understand the price that we are paying for everything. But Marilyn got some amazing things done in the state of Montana, things that other states, including my own state of North Carolina, have failed to do, including recently. And so tremendous credit it belongs to her. And not only did she get it done, but she got a pricing methodology that is unique to Montana, unique in the industry, and very defensible and verifiable. But I imagine that most employers and or brokers on this call don't have an entire state population behind them with which to kind of bring down that hammer and that claw and to really force compliance. Most employers have a greater fear over employee turnover and talent than municipalities tend to have. And so what do you do when you have an employer of any size and you're considering this option? How do you handle direct contracts or balance bills? Those were the two things that I kind of wanted to focus on. So when we first started building plans for smaller employers, we didn't have any direct contracts. What we simply did was we mirrored their current benefits, and we used reference-based pricing, a markup of Medicare, as the payment methodology. But we did have access to prearranged bundles with companies like PriceMD's, Access HealthNet, Bridge Health, eSurgeries, and many more. And we knew that those were vetted out for quality, unlike the PPO contracts. The PPO contracts and providers are really just licensed with the board. There's really no quality within a PPO network that is presented to the member. So we knew we were validating quality, and we were getting a prearranged price that was even a step above a DRG, because a traditional Medicare DRG excludes some things that would need to be repeated in the event of a readmission. Whereas in our bundles, all the costs, if there is a readmission or a complication, is fully on the provider. And so what we said to employees was real simple. We know that your plan is pretty painful enough. I mean, we've heard from Marty that the average American has $400 in their savings account, and here we are sticking them with $4,000 deductibles with another $3,000 or $4,000 to go on an individual if they're not HSA compatible, and double that if it is HSA compatible. I mean, you know, to Marty's point, I often feel like when I was a traditional broker and I was presenting to a board in a room that was making decisions for the company, I'm speaking to the 3 or 7% top earners in the country. And here we are making decisions like we're on some high horse. And I think Marty said it really well. We need to start to put ourselves in the shoes of not the highest paid employees, which are the ones that make the decision. And that's why brokers have leaned towards putting ourselves in the shoes of the employers. I get that. But at the end of the day, the ones that need this the most are the ones who have the least influence in the decision, but the biggest impact in the decision. And those are the lowest paid employees. And so what reference-based pricing allows us to do is, number one, control the price. I've long said there's only one way to pay less for healthcare, and that's you have to pay less for healthcare. All these other games that are wishy-washy, fuzzy, gray math, do wellness programs, do this, do that, they haven't worked. I mean, I don't know what, do I need to convince anyone they haven't worked? We've been doing them for years, and yet we wouldn't be having this webinar if they worked. So at the end of the day, reference-based pricing or some payment methodology that instead of the standard PPO contract is some starting price with a discount, is some known price with a markup, gives us a lot more control, a lot more ability to audit. So what do you do when you get a balance bill? Well, first of all, balance bills occur in all plans. And I know actually I'm calling them balance bills, but the buzzword lately has been surprise bills. I would like for one person in a traditional model to explain to me any bill that isn't a surprise when neither the patient, the health plan, or the provider of services knows what the price is going to be until after. Even if your insurance picks it up, it's still a surprise. The surprise is how much you have to pick up, and is it more than you anticipated or more than your plan said? Really, when we talk about surprise billing, that's what we're talking about if you really think about it. It's not the bill itself, it's did insurance pick it up or not? And remember, if we had plans where insurance picked up everything as we used to, we had an even higher cost trend than we do today. So we put reference-based pricing in, but the balance bill rate that occurs, honestly, is around 2%. We actually have fewer balance bills with a properly set up no network plan than we do with a network plan. When they show up, we deal with them. We negotiate with the provider. We don't make the member responsible. It's not the method that we take, but in most cases anyway. And we negotiate on behalf of the employer to try and get that bill down as low as possible. Very rarely do we have to pay above 200% of Medicare, and when we do, they're typically on very small bills like an X-ray or a lab work. So what we do is the very small percent that doesn't just flow through because the providers are so used to dealing with it, we talk with them about it. And now we have the leverage because they've already provided the service and we haven't paid them. So we just have a conversation. Now, if we see a high volume of balance bills at a particular provider, then we engage in a direct contract conversation. And even a small employer can create a direct contract because a self-funded plan with no PPO network can solve a lot of problems for the hospital. And the two biggest problems, the length of time it takes them to get paid. If you think about United Healthcare, which pays out billions and billions of dollars a year in healthcare, if they hold that money for an extra week or month or 2 months and make interest on that money, that's a lot of money for them, right? But employers, they don't want that interest. They just want to get the claim paid. And hospitals, they don't want that money withheld because to them, it's an accounts receivable and it's debt on their balance sheet. So one thing that you can do is you can say to the hospital, if you give us the right pricing, we'll waive any member out of pockets. You won't have to collect that. And that's a huge trigger for them that they really like. And then the length of time, you can promise them faster payment than 90 days as is typical in the PPO market. So even when you don't have the state of Montana behind you or a bulldog like Marilyn Bartlett, at the end of the day, you still have control of the price as long as you utilize the leverage that the real consumer has. And that real consumer is a marrying of the employer and the patient. That's the consumer. The last thing I'll say, and Al alluded to this in his opening, we got to stop referring to the carriers as the payers, because Marty made mention of it too. When you refer to the carrier as the payer, what it allows the hospital or the doctor to do is distance themselves from the financial consequences of whatever the course of treatment is that they're about to suggest. Or maybe they don't even know the financial consequences. So maybe it's an unknown, but yet if they truly understood that the payer of healthcare is the person they're looking in the eye, the ones they're suggesting that treatment to, I think it would force hospitals and providers to be more aware of the fact that there's a cost to this and be more conscious of it and hopefully have more of a heart. I have tried really hard with the help of my partner, Emma, to not point the finger at any one person and start to recognize that this is a systemic issue and we need to fix it systemically from the ground up, from those smaller employers up, not from the government or the carriers or the large employers down. Thanks, Al.
Sure, David. Before we move on and we put the peanut butter of what Marty talked about with the chocolate of the benchmark pricing that you just heard, we will show you the Reese Cup in a minute. But David, just one little asterisk on what you said about wellness vendors. I think what you said is true for about 95% of them, but there are a few that are validated by the Validation Institute, and It Starts With Me comes to mind. Quantum Health has shown some noticeable savings, and they're also, not coincidentally, I think there's 8 or 10 of them on this call. U.S. Preventive Medicine is what one might call a classical wellness company. And unlike other wellness companies that have gotten like a 1 or 2% reduction in risk, they're actually validated for a 9 or 10% reduction in risk, which is huge. And let me tell you, I put my reputation on the line for this. I looked at that thing up, down, and sideways because it would be very embarrassing for me to validate on behalf of the Validation Institute that number if in fact there were a major hole in it. This is not to say that you're not absolutely right about 95% of other vendors. Okay, so.
And you know, the one thing I will say, Al, and I spoke at a wellness conference just a couple of weeks ago, is whether you're in the 95% that isn't that effective or the couple of percent that is, if you use tools that lower healthcare costs by 30 or 40%, then you don't need an ROI on the wellness. You can take some of that savings and invest in the wellness of your employees and not even be held to an ROI standard, and instead strictly look at an outcomes and clinical state standard.
Well, what I would add to that, David, while we're talking about wellness vendors, is that I personally invited the Wellness Trade Association to invite their members onto this call because financial wellness and regular wellness come together in surprise bills, and that it's not just a healthcare issue, but as Marty said, you can bankrupt your employees with these things. I mean, if you have a financial wellness program, the number one source of financial stress for the plurality, if not the majority of your employees, is fear of or actually getting surprise medical bills. So with that in mind, let's put the peanut butter together with the chocolate and come up with a Reese cup and how you can actually solve this problem with what we call the mother of all consents. We're going to lead up to it a little bit here. First, I want to give you a sense of what the issue is by state. This is from the RAND Corporation, and as you see down in the corner, there will be a little source document, a source click-through that you can use. And this is the multiple of Medicare, and you heard Marilyn talk about multiples of Medicare that are being paid in the different large metro areas in the country by state. You can see an awful lot of states have a major issue with these multiples, which correlate closely with surprise medical bills. There is not direct information on surprise medical bills. Oh, by the way, the gray are states that RAND couldn't get the data for. The white, meaning Minnesota, the Dakotas, and Nebraska, as well as Alabama, Mississippi, and actually also Arkansas, I think, and Oklahoma, have a considerably less of an issue with these things than some of these other states do. And that also correlates with the Kaiser Family Foundation study that is not as visual as this, so I'm not showing it, but you'll be able to click through on it. That basically says the same thing as the RAND study does, but it's specifically about surprise medical bills. So to summarize, 57% of Americans report receiving one of these bills. As mentioned, few states escape this scourge. The odds, according to the source that we clicked through here, which was a survey, are 42%. 42%, 4 in 10, of getting one of these things for an ER visit or an admission, and that is in an in-network facility. Now, I'm old enough to remember when emergency rooms were loss leaders for hospitals. Trust me, that is not the case anymore. And it's especially not the case for the providers and the ancillary providers who populate these hospitals. And by the way, I should say that 42%, I looked for confirmation on it, and the Kaiser study shows a lower number. It shows something in the 20s. But still, I mean, these are huge numbers that we are talking about here. Huge numbers of employees, as Brian mentioned earlier, tens of thousands of these bills every day. And they're not going to Medicare members for the most part, and they're not going to Medicaid. They're going to your quote unquote covered populations. So it turns out that this is all solvable. And what I have done, and I was the one who did this, but I want to make sure I give absolute full credit to the other presenters on this call, because I only came up with this because I'm huge fans of Dr. Makary, Marty's book, read it very closely about the battlefield consents. I was not familiar with the EMTALA law that he talked about, looked it up afterwards, did a lot of research, and then I follow what Marilyn and David do very closely as well. David in general, and Marilyn and Montana, and learned all about benchmarked pricing. So what I was able to do, thanks to these folks, and once again, as John F. Kennedy said, defeat may be an orphan, but victory has many fathers. So I'm going to take a small share of the credit for this, but share it broadly amongst the other presenters on this call. Thanks to these folks, we have come up with a very simple statement that can be used as a battlefield consent, as Marty described, and has benchmark pricing, as you just heard from Marilyn and David, to solve the problem of surprise bills and emergency treatment when you check in. And that is, you take a little card that says, I consent to appropriate treatment and to be responsible for reasonable charges not covered by insurance up to 2 times the Medicare rate, and you sign it. Here's what you have to know about this. The law that enables this language that Marty referred to earlier is called the Emergency Medical Treatment and Active Labor Act of 1986, and you'll have a click through to learn more about that. It essentially means that anyone who comes into an ER and consents, or their person who brought them in consents, or consent is implied if they're unconscious or something, must receive treatment regardless of ability to pay or the payment method. This specifically includes testing, well, besides just being treated in the emergency room, all tests, admissions to the hospital, deliveries, that's why they call it the Active Labor Act, and transfers to other hospitals. I want to be very clear, it does not include anything elective. I mean, we've had a few questions, comments have already come in that have said, well, we solved this with bundled pricing. No, bundled pricing does not apply here. This is this is not a contracted thing. This is an actual, because these people are out of network. The providers who are sending you these bills are out of network, so there's no contracting involved. The private equity industry generally owns a lot of these practices and have figured out that they can make a lot more money taking them out of network and billing. And I even know some of the folks who are making a lot of money on this stuff off of us. So let's parse that language a little bit. It says, I consent to appropriate treatment. Now, absent the word appropriate, you could easily be overtreated and be billed for that. And it says up to 2 times Medicare, and which is a number which is very close to the number you saw from Marilyn, essentially identical to what Dave told you. He called it 200% of Medicare. If you don't put a reasonable price in, they could treat you. And then you could debate pricing later. They would not get the price that they want, but you may not get the price that you want. And I suspect, and I don't know this, in the case of the example that Marty gave about the hospital saying, thanks, we just won't charge you at all, is they didn't want to go to court. Because if you go to court and you got somebody like Marty on your side, and you end up only being able to pay, in Marty's case, I believe he said he was willing to pay the Medicare rate, and you get ruled against as the hospital, that means you're going to be ruled against in every single case because precedent has been established. So the hospital just said, thanks, we'll just do that one for free. But you also can't really go in and just say, I'm going to pay the Medicare rate, because then the hospital could, I think, very fairly say, no, we're not going to accept that, and maybe take their chances in court later. But the Medicare rate is for a vast number of people that was carefully negotiated. 2 times the Medicare rate is a very reasonable price to pay if you walk in off the street. Now, I mentioned before about appropriate testing. Well, here's a news flash. Now, Marilyn pointed out that that testing or outpatient has not risen lately in terms of utilization. But as she said, it's plateaued, but at a very high level. And to put some color around what she said, this is the United States versus the rest of the developed world for MRIs and CAT scans alone. And mind you that most of these countries have better health outcomes than the US. The average is in red. If you want to find the United States, you don't have to scan. Here's a hint, don't scan from the bottom, scan from the top, okay? In MRIs, we're number 2. In CAT scans, it's not just that we're number 1. It's if CAT scans, you might remember we didn't do very well in the Olympics last year, but if CAT scans had been an Olympic event, we would have run away with the gold. Okay, so people want it. They build these facilities. They want to scan you. The hospitals want to scan you. They make a fortune on it. So here are the keys to using this battlefield consent. A lot of you on this call are brokers or from HR. You can, or benefits, you can put this right on the employee's insurance card. It's only one sentence. And the employees should keep this card in multiple cards in multiple places, because by definition, you don't know where you're going to be when you have an emergency. You know, wallet, glove compartment, bike bag, home, essentially wherever you like. And as Marty said, don't sign any form consent, even online, other than this. Make sure the intake person sees this if you have your wits about you. Remember, you're in the emergency room, so you know, this may be a lot, but it's as easy as it's going to get. Take a picture, you know, document yourself. As a benefits or HR or broker, educate your employees on how to present this card, because it only works if they use it. It's not like insurance. Insurance works if you don't have your insurance card. This you actually have to show. And we actually made the consent language downloadable. This card is downloadable. There's one piece of paper that will have 8 cards on it that you can slice up. And Quizzify, which is my day job, which is teaching employees the ins and outs of healthcare, we are providing our surprise medical bill quiz gratis to everybody on this call on a link. There's no sign up involved. You can just give your employees this quiz, and it includes related topics as well, like freestanding ERs versus urgent care. So here are some typical Q&A that we get asked a lot about these battlefield consents. You know, what if the ER doesn't accept it? Well, you heard what Marty said. You basically just consent to treatment, and then you can argue about it later. And whether you win that argument or not, I don't know, but that's your fallback, is you just write, I don't agree to the charges, or I consent to treatment. And then you won't get a huge bill, but we don't know what kind of bill you're going to get. Next question is, does it apply in freestanding ERs? Well, that's actually a slightly subtle question. If the ER is owned by a hospital, which means that it has a hospital license, it's accepted. They have to accept it. If it's a freestanding ER, they don't have to accept it. Must urgent cares accept it? Once again, owned by a hospital, EMTALA applies, but urgent care centers rarely grossly overcharge. And in fact, one of the things that we try and do in Quizzify is educate people on the difference between freestanding ER and urgent care, try to get them to go to urgent care. Now, to wrap up, let's circle back and apply what you've seen here to Brian's original bill that he showed. Now, you may recall, well, it wasn't that long ago, so I'm sure you recall this slide where he actually took a screenshot of a piece of the bill that was 5 pages long. Now, let's just blow up the first 6 items on Brian's bill. And what Brian did was, for each of these 6 items, he looked at the self-pay charges and the Medicare rate. Now, the first thing you're going to notice is that, well, I mean, it's almost impossible not to notice that, in fact, the Medicare rates have 1 fewer digit in them than the self-pay charges do. And in fact, the self-pay, the lab charges generally are 16 times the Medicare rate. So now let's see what happens if you apply this consent. If that person had that consent handy, what would have happened? Well, I don't know why that, here we go. The first thing, oh, I know, I want to just draw a little attention to the 5th item on here, which is the pregnancy test. This woman was not of childbearing age. She should not have gotten the pregnancy test, let alone be charged $111 for it. So we're going to just take that thing out altogether. And remember, as Brian said earlier, there are a number of inappropriate, undocumented charges on that bill, things that may never have been done, let alone whether they should have been done. So this is just an example of something that's going to come out of the bill. So that puts you at $33.51. You then multiply that by 2, and you get $67.02, which is almost exactly 90% less than the current bill. So is it going to cost money? Of course it is. It's a hospital service. People deserve to be reimbursed. Are you going to get reamed? Absolutely not. So with that, I'm going to turn it over to RD, who will wrap up, and then we have time for some Q&A, because incredibly, despite the number of speakers we had, we did finish on time.
Thanks, Al. the great presentation for all the speakers, and hopefully everybody learned a lot today, and we're going to get to the questions. But before we do, next slide, please. Just want to remind everybody there's a lot of resources that you're going to have access to following this call. On this slide here, first of all, we've been getting a lot of questions while the webinar's been going on. Everybody will receive a link to the recording in the slides. Even if they did not attend, they will still receive that as well. But it's amazing how many of our huge sign-up have come on and stayed on the whole time. So fantastic, and we're going to get to those questions. But here's some resources that you can immediately put to work after the webinar here. Next slide, please. I want to specifically sort of point out the Certified Health Value Professional program that I mentioned. It will teach you lots of techniques, as you're kind of dealing with lots of challenges in the buying of healthcare benefits. It will teach you lots of techniques on how to deal with them. Peer learnings, peer shared learnings. It's a fabulous program, and we're making it available as inexpensive as possible. By participating on this webinar, you're gonna, if you just use the special code BILLING, B-I-L-L-I-N-G, which is here on the slide, we're going to reduce the cost right down to $895 from $1,195. And again, this counts for SHRM recertification credit. So got to do that anyway, and this will kill two birds with one stone there, and you will be a health value master buyer. So next slide, please. We're going to get to the questions here. First one, Al, we have in here, I'm just going to pick a few of these. How might national legislation affect this?
There are two, first of all, to the extent there's any national, first of all, one very important thing to know is that there are state laws, but ERISA is federal and preempts the state laws. So that if you insure your own employees, the state laws generally are not going to help you. So let's now go to the federal. If in fact legislation happens, it could go one of two ways. One is it could go to an arbitration process, which is the technique that's used in the New York and the New Jersey laws that are in place, where you put in the price you're willing to pay, and it's like Major League Baseball. In fact, they got it from Major League Baseball. And the provider puts in the price they're willing to pay, and the arbitrator picks one or the other, with the losers to pay the cost. That has helped prices come down in New York, but they were already very, very high to begin with. So they're still quite high. If that type of law passes, this consent is still, it's incredible. If anything, it becomes more valuable because it will support the arbitration case. And so that's one type of law. The other type of law is where out-of-network prices are benchmarked to a Medicare benchmark, in which case, basically, you just will have wasted 53 minutes because you're not going to need a consent, and this will all be done for you. My suspicion is that to the extent anything happens, it's going to look more like arbitration than like benchmarking.
Great. And there's last question coming in. If anybody has questions, just go ahead and put them right into the question box in the webinar. And if we can get to them now, we will. And if we can't, we will research the answer and get back out to you. The next one I have here is, this is a good one. What if you're unconscious?
Marty, I think I'm going to turf that one to you. If you're not accompanied by somebody, I have no idea what happens. So I'm going to turf that one to you.
Well, look, if there's a life-threatening situation, we need, as doctors, to take care of you. We're not going to give you a price. They're not going to ask you to sign your financial life away. No family member should agree to that part of any consent. And we as doctors and hospitals do not rely on any paperwork to take care of somebody who's unconscious. We have a duty to treat. So it does raise an interesting point, though. What about the services that are not shoppable, that are not elective, and that are not bundled? What about those, the sort of ICU stay where you simply cannot really keep track of things and be an informed consumer? I agree with David Silverstein that proxy shopping affects entire markets. For example, when I go to the grocery store, I'm not comparing the price of a lemon in one grocery store to the price of the lemon in another grocery store. But my mom does. Her and her friends represent proxy shoppers. They're about 10% of people who shop in those grocery stores. And people like her keep prices in check for all of us. And it's the same in healthcare. Health plans, employers, those who have high deductibles, out of network, the uninsured, those informed shoppers, or the fraction of them, the subset of them who do shop based on price, are proxy shoppers to keep markets in check for all of us across all services. So that EKG machine, when proxy shoppers, even though they may represent a subset of shoppers, are shopping using the value proposition of price and quality, they keep that EKG price in check when it's used at the time of an emergency or for an unconscious patient.
Excellent. Thank you. We got a question in here. Can you clarify the 16 times of Medicare for lab charges that was mentioned?
Brian?
Brian?
Well, actually, you know something? Actually, I think we just go back to the slide here.
Yeah.
I think that this was the issue that that Medicare. Actually, Brian, if you're not muted, since you're the expert on this particular topic, I'll turf it to you. I think Brian's muted.
Here we go.
Brian? Okay.
All this is the numbers that are in the self-pay charges column were what was listed on the bill, and we went back and found the Medicare payable rate for each of those items, and then we calculated the difference, which is right at 16 times. I think that covers it.
Great. Thanks, Brian. Al, I got another question here. How come no one's ever thought of this before if it's such a good idea?
Well, that's a very good question, and I, you know, when I thought of it, my first thought was there has to be something wrong with this, because who am I? I'm a mere, you know, vendor of you know, health literacy services. So I went to my go-to folks, Marilyn, for example, and Marilyn's idea I thought was the same that mine, and she said, I'm going to show it to my my in-house attorneys. And Marilyn, tell me if I'm misquoting you, but their first thought was, oh, we can't do this. And then I said, wait a sec, why can't they do this? So that was my reaction as well. Now, in terms of why nobody's thought of it before, there's a, you know, I used to teach economics, and there was a joke that would go around about economists, which is there's an economist and his friend walking down the street, and they see a $10 bill on the street, and the friend says to the economist, look, there's a $10 bill on the street. And the economist says, nah, if there were a $10 bill on the street, somebody would have picked it up by now. Okay, well, you know, this is the $10 bill, and what you're listening to is we're picking it up.
Great. We just took 2 minutes left here on the hour, and just maybe just a chance if any of the panelists from today's webinar, and thank you to everyone, would like to make any closing remarks.
I'll say something briefly. This is Marty. I really believe we've got good people leading American hospitals, and we've got good people on the insurance side too. But these are good people working in a bad system. Matter of fact, it's not just a bad system, it's an insane, crazy system that no one ever designed to grow into the monster that it is. It is a game of inflating prices for the purpose of offering secret insurance discounts. So the more transparency we can get, the better. If airlines billed us after the flight, they'd be gouging us all over the place. If travel sites had no prices, we'd be living in a world of price gouging and surprise bills for beverages consumed on airplanes. But we've all priced that into competitive markets, and I think transparency is the great value that we all need to ascribe to, rather than playing the blame game and talking about individual bad actors in this market.
Great comment. Any other comments from our panelists before we close out?
This is David Contorno. I will turn my webcam back on. I think that transparency really needs to, I mean, Marty's talking about it from the provider community, and that's super important. But I think brokers and consultants need to do the same. The way that we get paid ultimately impacts the advice that we give or the boxes of solution sets that we look for. When I started to get paid from the client and the client exclusively, there was no box. Any solution set that would help me meet the goals of the client, which was generally lowering costs and improving quality, became an option. It's all about the financial incentives. Like Marty said, there's a lot of good people in our healthcare system, but when the financial incentives are aligned so that higher costs and lower quality equals more profit, in aggregate, those are going to win out the day. And those are what we need to change. And only with transparency, true transparency, can we achieve that.
Thanks.
This is Marilyn, and I would add one thing. As I look at transparency, I agree totally with what you said on the price transparency. But we're starting to also focus on transparency overall of hospitals, organizational transparency. What about not-for-profit status? What about 340B profits? What about what is truly uncompensated care? What is truly charity care? And those are things that I think we can address or start to talk about from a legislative side. I think there is a lot out there with hospital transparency that needs to be addressed.
Excellent, excellent. So this slide here that you're seeing, again, you will receive these slides and the full recorded session, but these are resources that you have access to now. Appreciate everybody listening in on the webinar. Any other, just want to make sure I gave everybody a chance to put any closing comments in. Al, anything to close it out?
What they said.
Okay, great, excellent, good. And everybody be on the lookout for follow-up emails and additional resources. We'd like to thank our friends at Health Rosetta and all the panelists on today's call for a valuable call. And look for more information to come to help you improve your healthcare benefits and lower costs and improve healthcare in America. Thanks to everyone on the call today. And thank you, Al, for organizing.
My pleasure. Thank you.
Great. Thanks so much.
Okay, I think we got the Reese's Cup all set. Thanks. Bye.